I'm just going to talk a little bit about the management of viral infections of the cornea, and primarily I'll be focusing on herpes simplex keratitis because viral infections is too broad a topic to cover entirely in the given time, right? So I have no relevant financial disclosures. So if we look at the viruses that affect the cornea and the eye, so there's a list of the viruses that affect the eye, and also parallel to that you have a list of drugs that we commonly have available to manage these infections. So we won't be going through all of this. Primarily we'll be concentrating on HSV infections of the eye, right? So herpes simplex can cause anything from an infection of the eyelids, which is blepharitis, to conjunctivitis, both of which are very common in primary infections. What cornea specialists are usually confronted with is epithelial, stromal, endothelial keratitis, or a combination of these, along with iridocyclitis. Less common are episcleritis and scleritis and posterior segment manifestations. So mainly we'll be focusing on the HSV keratitis part. So first things first, it's very important to get the terminology right, because there are a host of descriptions used for these infections, like geographic ulcer, dendritic ulcer, necrotizing keratitis, non-necrotizing keratitis. So the simpler way to classify these infections is to look at these in terms of the layers of the cornea. So if we have only epithelial involvement, it is best termed as HSV epithelial keratitis. If you have stromal involvement, that would become HSV stromal keratitis. This can again be with ulceration or without ulceration. So that more or less takes away the confusion of thinking about it in terms of necrotizing or non-necrotizing. So you have HSV stromal keratitis with or without ulceration. And then there is HSV endothelial keratitis, or alternatively called endotheliitis. So the key here is to stain the cornea, because you cannot make out epithelial involvement clearly without staining with fluorescein and other dyes. The other important aspect is to make a thin slit. Therefore, you can detect the areas of edema, the areas of thinning, necrosis, and stromal loss. So if you have access to a good slit lamp, which all of us do have, and you have some fluorescein strips, there is nothing much else required for a diagnosis of HSV keratitis and further management. Additional tools are available, such as viral sequencing, PCR, etc., but they are mostly limited to tertiary care centers in very few cities across the country. So I'll be going through some of the clinical manifestations of the disease and what are my recommendations to the ophthalmology group for managing these. This is a combination of evidence and practice patterns. So HSV, there's no clear consensus on which drug to use, how long to use. There are some landmark trials, but they have their own limitations and they were not done in the context that we often see patients in. So epithelial involvement is the most common form, and it's important to know that this is actively replicating viral infection on the surface of the cornea. So these are the two key takeaways. It's the most common form, and it's an actively replicating virus on the surface. So typically you'll see something like this, which is called dendritic ulcer. It looks like it has multiple branches. It can be linear. Sometimes those can merge into what we call a geographic keratitis. So these are multiple dendritic lesions all over the cornea, stained with fluorescein and rose bengal. And when it merges into one common confluent ulcer, this is what we see, which is what we call a geographic ulcer. So all of these are termed as HSV epithelial keratitis, and that makes the management simpler, because if you think of it as HSV epithelial keratitis, it's easier. The same lesion stained with both fluorescein and rose bengal. Again, an example of unstained and stained pictures of the cornea with HSV epithelial keratitis. So what is the management for these ulcers or these lesions? So it's very simple. In our context, because we have topical acyclovir preparation readily available, the simplest recommendation is to use acyclovir eye ointment 5 times a day for an average of 2 weeks. This is not hard and fast, but generally till the ulcer heals. The alternative, which is practiced and recommended mostly in the US because they don't have topical acyclovir, is oral acyclovir. So that is also fine. One can use either topical or oral acyclovir 5 times per day till the lesion heals. The only caveat is that oral acyclovir is much more expensive. With ointment, sometimes you may have toxicity, which is difficult to detect unless you can distinguish between the ulcer and the toxicity of the ointment. So if you feel you've adequately treated the lesion, but you're still having some punctate keratopathy, which is staining with fluorescein, might be a good idea to withdraw the ointment after a couple of weeks and see how the lesion goes. Right. An alternative to acyclovir is also ganciclovir, again which works equally well but is more expensive. So this is how that lesion which I last showed you heals with acyclovir ointment and nothing else. So there's no role for lubricants, no role for antibiotics, no role for any other placebo therapy. Just use acyclovir. And these are the recommendations that I laid out. First choice would be acyclovir eye ointment. Alternatives are either topical ganciclovir or oral antiviral therapy. And this is the take-home message, that you need only antiviral agents, and please avoid the use of topical corticosteroids in this management of what is just HSV epithelial keratitis, because that often complicates things. Stromal disease, as I said, can be with or without ulceration. This is more commonly seen in recurrent cases, and the important thing to note here is that it is in general an immune reaction to the viral antigens in the stroma. This can be with an additional component of active viral replication, but the major manifestations that you see, the stromal infiltration of white cells, the necrosis of the stroma, the destruction of the cornea, is due to an immune reaction of the body's immune system to the viral antigens. And once we know that, it becomes easy to manage. Right? So HSV stromal keratitis is commonly known to recur. So if you have multiple episodes, you may think about prophylaxis. And repeated infections, repeated stromal keratitis with or without ulceration commonly lead to scarring with vascularization and therefore vision loss. So HSV stromal keratitis without ulceration, here is an example where the epithelium is intact, but you see areas of scarring where there were prior episodes of viral keratitis, and there's active cellularity in some areas. The vessels are not very clearly visible here, but on higher magnification one can see the deep vessels, which is a good clue. And with therapy, it starts to heal, and over a period of time completely scars. So what is this therapy? I'll come to that. So if you have stromal keratitis with ulceration, what makes it slightly different is that intact viruses have been recovered from these lesions in addition to the immune component. So you have an ulcer which looks like this. Typically you have epithelial defects with stromal infiltration, and the key to diagnosing necrotizing stromal keratitis or HSV stromal keratitis with ulceration is that there will be tissue loss. So if you make a thin slit rather than edema, you will see areas of thinning, and these are lesions that are at a risk for perforation. So you need to be careful about that. With treatment, again, these lesions heal very well, and this is how it looks on resolution. Another example, unstained and stained, and this is how it resolves. More severe example, you can see the thinning, which is almost 80–90% superiorly in the cornea, and how this lesion heals. So you have this combination of epithelial geographic lesion with stromal infiltration with a hypopion. So this is HSV stromal keratitis with ulceration with anterior uveitis, and this is how the lesion heals. So what is the treatment? The primary treatment here is steroid, because you have to treat the immune component. So typically I would start prednisolone acetate eye drops 6 to 8 times per day and taper based on the clinical response. The key being to taper very, very slowly. So typically it can be over weeks to months, depending on how severe the infection was, how severe the lesion was, and how recurrent the lesions are. If it is without ulceration, my choice is to use for acyclovir oral in a prophylactic dose, not in a therapeutic dose. So I use it 400 milligrams twice daily. The idea being to continue it in the same prophylactic dose, because these are patients at a risk of recurrent lesions and vision loss. If there is ulceration, one should use therapeutic dose of either oral or topical acyclovir till the epithelium heals. There are two different practice patterns here. Some cornea specialists prefer to treat the epithelial part first and then add steroids once there are signs of epithelial healing, and this is what I would recommend. There are others who feel that both the treatments should be started simultaneously. So the take-home message here is that a topical corticosteroid, typically predfort or prednisolone acetate, in conjunction with either an oral or a topical antiviral, most commonly oral because you want to continue it as prophylaxis, for at least 10 weeks is the preferred treatment for HSV stromal keratitis, and the balance between the antiviral and the corticosteroid components of therapy has to be judged. You know, what component is more, whether you're dealing with more of an epithelial lesion, more of a stromal lesion, is the inflammation recurring on stopping the steroids or tapering too fast? So that's a judgment call for the specialist to make. Endothelial keratitis in terms of pathogenesis is very similar to stromal keratitis in the sense that it is mostly an immune reaction to the viral antigen. So keratic precipitates, raised IOP, iritis, AC inflammation, and localized areas of edema are the hallmarks of HSV endothelial keratitis. This can be linear, disciform, or diffuse. It doesn't really matter what form you're dealing with. Essentially, the pathogenesis is the same. I'll just show you examples of each. So this is what we call a disciform lesion, a disc-shaped area of edema, and this resolves very nicely with therapy, and you can almost, it's impossible to make out where the edema was. This is a linear lesion, and you can see on the slit that there is cellularity and there is edema in that area, and it resolves very well. I unfortunately don't have an example of a diffuse lesion. So the primary treatment here again is topical corticosteroid. Prednisolone acetate started 6 to 8 times per day and tapered as per the response. And why do we use acyclovir here? We use it so that we don't have an epithelial recurrence of disease. So while you're using the steroid, you don't get a geographic or a dendritic lesion. So again here, I would use prophylactic dose of oral acyclovir, 400 milligrams twice daily. Some surgeons prefer to use a full therapeutic dose. That is also fine. So the take-home message is a topical corticosteroid agent is the primary treatment, and it should be combined with an oral, and few surgeons use topical acyclovir in this context. Where do we want to use tablets rather than ointment? These are the recommendations. If you have iridocyclitis, trabeculitis, more severe, more deeper infections of the eye, pediatric age group where ointment might be difficult to apply, immunocompromised patients, and for prophylaxis. So what are the indications for prophylaxis? Multiple recurrences of any type of HSV keratitis becomes an indication for prophylaxis. How do we define multiple? Well, typically more than 3 a year. So 2 is maybe not multiple, but 3 or more would definitely qualify. You have to qualify this in the context of whether the lesions are occurring in the center of the cornea, whether it is causing significant scarring every time it occurs, vascularization, and then take the call. Another major indication for oral prophylaxis is after keratoplasty for presumed or proven HSV keratitis. And then there are other indications that I have listed here. The options are either acyclovir, valacyclovir, or famciclovir. There are some special situations which require systemic acyclovir, such as neonatal HSV, because there is also a risk of encephalitis, not just the eye infection. So these need to be treated with intravenous acyclovir, preferably with the help of a pediatrician. If you have patients with A2P, they are known to have higher incidence of bilateral HSV disease. And then there are some more technical aspects which would interest the cornea specialists more, so I'll quickly skip this in the interests of time. What are the differences between the oral drugs available? This is something that I commonly get questions on. Is ganciclovir gel in any way better than acyclovir ointment for HSV keratitis? The short answer is no, it is not. It is more expensive. It is probably has a little less toxicity than acyclovir ointment, but for most of the cases that we deal with, acyclovir is equally efficacious. In fact, in terms of penetration into the anterior chamber, it is better than ganciclovir, so I see no reason for using a more expensive drug. There are other drugs which are used or have been used in certain trials, but we do not generally use. And then there are other viruses which I'm not going to talk about right here, like adenovirus, VZV. CMV is something I'll quickly touch upon before ending, because it can be confused with HSV infection. So this is more likely to cause what you call an endothelitis or an endothelial keratitis, and not only in immunocompromised patients, but majority of the patients are immunocompetent. The way it has been described is you have coin-shaped discrete lesions, linear keratic precipitates, and you have raised IOP. So if we have a patient who is presumed to have HSV endothelial keratitis, anterior uveitis, but not responding to conventional treatment, it might be a good idea to, if you have access, do PCR for CMV, HSV, and VZV, or refer to a center which can do it for you. The treatment here is systemic ganciclovir, but there are recent reports where topical ganciclovir has been used with some success. So that pretty much sums up what are my recommendations for managing viral diseases of the cornea. Thank you very much. If there are any questions, I'll be happy to take. Yes.
Underdosing of any antibiotic is probably not advisable nowadays because it is a policy matter. So even for the prophylaxis, you have to administer full dose.
So 400 milligrams twice daily is what is the recommendation based on clinical trials and what has been used the world over. Maybe the panel might want to chime in with their thoughts. Anyone using full dose of acyclovir as the gentleman suggested for prophylaxis?
The recommended is oral acyclovir, 400 milligrams twice daily, duration.
We don't know. We don't know.
Lifelong duration.
Right. Yeah.
It is based on the head study.
So this is not something I have come up with. It is based on very good evidence.
I think we'll take in more
Yep, sure.
questions at the end because the times are allotted for that.
Yes.
And I will ask you to join us here so that it will be easier for us to ask questions.
Is undergraduate